Are you losing patients to a bigger competitor like a hospital or a health system, or if you're in the dental world, maybe a DSO? Well, so was my guest today, but he's taking patients back from the hospital and sharing insights on how he's doing it. I'm Carl White, principal at Mark Advisory Group, which is a healthcare marketing agency, and I'm also the host of PracticeCare. The mission for both is the same, and that's to help private practice owners stay private. Let's just all agree that care is better when the doctor or the provider owns the place and has the most freedom possible to make the clinical decisions they think are necessary. And my guest today is Christopher Formanek. Christopher Formanek is a renowned podiatrist and the founder of Footsteps, which is located in Baton Rouge and Gonzales, Louisiana. Dr. Formanek is a board-certified Diplomate Minimally Invasive Foot and Ankle Surgeon, and his clinic specializes in minimally invasive foot surgery. And Dr. Formanek, thank you for taking some time to come on PracticeCare and tell us what's going on.
Thank you for having me.
Yeah, absolutely. So let's start, just kind of set the stage for us. You know, how long have you been, a little more background on you, how long have you been practicing podiatry? And to kind of get into it, when did you notice that the hospital is starting to kind of, siphon off patients, and what type of patients? Set the stage for us.
Correct. Well, I've been practicing 20 years in two clinics, a very diversified practice, very successful practice. And I'd say it's about 4 years ago, just prior to the pandemic, that I started noticing the behavior of the hospitals, with a lot of mergers, acquisitions, partnerships, and keeping things internal and not referring out as much and just to give a little context of that, I kind of saw this coming 4 years prior to then. So I was ready to prepare for that because I knew what CMS was doing and why this was. We're all familiar as physicians with all these Medicare Advantage plan audits, and they would end up costing CMS a lot of money because these audits would make the patients look very unhealthy. So CMS finally realized this wasn't working and costing way too much. So they were going to give all the power to the hospitals, basically. And I saw that coming. And this was part of it with the new medical model where there's internal collaboration, less redundancy, more integration. And it's all fine and dandy. It saves a lot of money. I think we can all agree with that. But it comes with a caveat. And we're starting to see that now. And I saw this coming 4 years ago, that a burden is now being placed on the hospitals because everything is going to be bundled starting this year. We're seeing that in procedures, hospitalizations that we didn't see before. I think a good example of that is I do many procedures, and I've done many in the hospitals, and I do outpatient. But now the new change coming is that the hospitals will be reimbursed one fee, and they're going to allocate it amongst all the providers involved in the care, basically. And what happens is there's going to be a lot of squeezing that we didn't see before. And we're starting to see the effects of that. And I think this can be very advantageous to the outside practitioner, the solo practitioner like me right now.
So, and the bundle, that's the bundled payment. So for a, a foot, I'm going to butcher this, right? But for a foot surgery, there's X amount of dollars, and, hospital, that's what you're getting. That's all. Okay. Yeah.
I can give you an example here. A standard bunion 28299 is a correction of a bunion with a double osteotomy. I'm cutting the metatarsal head and the phalanx. So I do a lot of these in the hospital. The 2023 reimbursement for me, if I do it there, is going to be $599. Now, if I do the same thing in my office, is $984. The hospital will get reimbursed for that $6,397, but they have to allocate that. What's that?
10 times what you would charge.
Yes, but they have to allocate, and they used to have that. That's how what formerly we're used to me being paid, hospital being paid, anesthesiologist being paid, everybody being paid. Now it's all bundled into one payment. And the hospital administration will allocate those fees. So all of a sudden, everything is getting squeezed. That includes the pre-op workup, history and physical, lab work, post-operative, physical therapy, fixation. We're actually seeing the effects what the hospital is doing now, because instead of pre-op histories and physicals having to be done within 30 days, they're saying 6 months is fine. Lab work, 6 months is fine instead of 30 days. They're already compensating to save money by lowering some of those standards, which I think is quite interesting.
Yeah. So the 6,000 or so, that's what the hospital always got, but they weren't sharing it with as many others. Is
Correct,
that what it
correct,
is?
correct.
Okay.
This is the new rule. And now it's all going to be bundled into there. So everybody's going to feel the squeeze. And this is great for what I do as we get into
Yeah.
some of the niche things. And you'll see why. But
Okay. So what types of patients were you starting to see the hospital, like you would normally get them, but you're like, man, the hospital's taking some of these patients?
well, and it was bad because people I knew who were my friends, some of the nurses saying, "Why don't you see our podiatrist?" I understand why they're doing that. All the MIPS and tips and the
Yeah.
credits they need, but it's a money thing, keeping it internalized. They want easy access to that. So they were actually taking my patients. My patients wanted to see me, many of them still, which I thought was interesting. And I saw this starting 4 years ago. Um, and it was all sorts of patients. It didn't matter who the
Mhm.
patient was. But what's interesting in my niche thing that we're going to talk about, I'm attracting a lot of, certain types of patients that are not good candidates for what they're doing over there in terms of
Right.
procedure, some of the
Right.
niche things.
So what types of, I mean, how would a patient be, I'm using various sort of black and white terms, be sort of taken from you? How would a patient be swerved away from you and over to them? What was the
Interesting.
mechanism?
It's such a coordinated effort with health and wellness nurses, with physicians, just standardly saying, "Why don't you see our podiatrist?" That's a common thing because I'll have my patients tell me that. And
Mm,
some of them I've seen and some of them don't. Some of them come back because I offer unique things. They like my office, my staff, but they would actually put that out there. And they're the power player. And I was in one of my satellite clinics, for many years, very established there. So I kind of took pride that they looked at me as competition because they're like 1,000 physician group and I'm a soloist. And they're
right.
saying that's the competition. Interesting.
Yeah. Well, size doesn't always matter.
No,
So these are like, the hospital's kind of primary
correct,
care fleet of
correct.
doctors and nurses saying, we've got a lot of good ones just in here. Why don't you stay in
Exactly.
here? Is
Quite
that what?
coordinated. Yeah, and it takes them longer to see the patient, and things are different.
Yeah.
But yes, so I found that kind of insulting, and it was all because of being in that network, in that hospital network,
Hmm. And
directly
were
where they
you
could
were you
internalize.
one of the so you weren't one of the hospital podiatrists per se, but were you
It's
like,
interesting. I've been on staff at these various hospitals for 20 years, and I was kind of the de facto podiatrist at one of them where they thought I was on staff. I was the only non-MD who could vote in the meetings for 10 years. So I thought that was interesting. But I was doing very well, such that one hospital hired a podiatrist. Um,
okay?
and we're basically across the street from each other at one of my clinics, the hospital across the street, which hasn't worked out too bad. That's how CVS and Walgreens does it. And we
Yeah.
actually found that it raised both of our values up being right next to each other too.
Right. That's probably a reason why all car dealerships just all seem to
And
be down the street from each other.
another interesting point, exactly, with one of the deals, the negotiations that the hospital, the largest hospital group has, is they have a deal made with the public aid programs where they get reimbursed at a rate, I believe, 3 times higher than what I would. So they're mostly seeing patients that I don't see typically because I have more of a hybrid niche practice that we'll get into where I select more of the insurances that I
Okay.
want to see in the things that I do. So the reality, a lot of the patients that they're seeing, I'd say at least 60% of the patients they see, I'm not taking those plans.
Did you used to though?
I didn't. I
Okay.
didn't for various reasons. I don't like all the hoopla of all the authorizations having to see the patient. And I found that many of these community plans don't cover the services that I offer.
Hmm.
Some people get toe corrected, this and that, and they just weren't covering it. So I found it more burdensome for my staff. And that's kind of where I draw the line. And, when I kind of look at the workload required, and if there's somebody across the street who wants to do all this stuff, we can let them have that
Right.
because my reimbursement is a lot lower. So it kind of ties into working smarter, not harder.
So 60% of the patients are probably not an overlap with the hospitals. But
Exactly.
does that mean that 40% are?
Yes. And
Eh,
this is just a broad estimate. Yeah.
Sure, understood. And so if
Mhm.
they really, so 40% is at risk. That sounds like a
Yeah.
material concern.
Oh, it is. It is. It is.
Okay.
And more importantly, it's all the new referrals where I used to get all of the referrals. I don't get nearly as many. I get some for second opinions and that. But
Mm,
I know how it goes because I have friends in the system who tell me if they want a referral to me in the Epic, they ha- I don't pop up right away. It's kind of a roundabout way to get to me. They're really featured on their
yeah.
provider. You
Yeah.
know, And I actually think, if they do it too much, they probably have a discussion with administration,
Yeah.
on that part.
Yeah. I heard this
A lot of
story once. I don't know if it went anywhere. I want to say it was in New York State. I could be wrong, where somebody was suing a health system because this freedom of choice was curtailed on referrals. It was saying, isn't there some sort of anti-competitive something going on if, because the freedom of referral is not to anybody you think is best, but only
you're,
within the system.
you're exactly right. And we see that even with home health agencies that they choose to contract with, in physical therapy groups and whatnot, and partnerships, people who aren't officially in the group, but have a partnership arrangement where they bring surgeries to the hospital if they refer. I mean, there are a lot of interesting arrangements, we'll say.
Right. Okay. So you saw this coming about 4.5 years ago.
Yeah.
So did you decide right then and there, man, I gotta fight back, or I gotta get on this? Or did you like try to work it out with a hospital or some sort of negotiated something or other? What did you, once you saw it, what did you decide to start doing?
It was, I got to get on this basically, and I got to prepare myself. And I kind of had some ideas in the back of my head because historically I've offered unique services, and there are certain things I do that they cannot do over there. Whether it be on a skill set of training that I have. A lot of larger groups are concerned about getting into durable medical equipment, which I think is a big part of what I do in podiatry. Certain programs are afraid of the audits, the cross-linking, the bundling. They don't understand, where I have good knowledge of that. Certain services that I was offering that they are not was a good thing. But I was also preparing myself with something called minimally invasive or minimal incision surgery. And I went to my first conference in 2012. It kind of blew me away. I went there by mistake. It was a whole different way of problem solving.
It's a great mistake.
I felt I was in a different universe. When I went in there, they gave me headphones. I said, "What's this for?" I said, "You'll need them." I felt I was at the UN. It was an international conference.
Awesome.
But everything I knew about how I approach things surgically, it was a whole different way of looking at problems, basically. And I came out of there, my head was shaking, with all the things I learned. And I said, "I'm not ready for this yet, but I can see I'm going to need this upcoming." And then a few years later, I saw this happening with the hospitals, the inevitable thing. And I said, this is the time to implement it. And I really started implementing it during the pandemic, when nobody was going to the hospital or surgery center. They're going to my office where everything was secured and having their procedures done minimally invasive, the tenotomies, the bunions, the hammertoe correction. So I was actually doing quite well. And I had actually my best year last year that I've ever had in 20 years of practice.
Wow.
Which is interesting. And even during the pandemic, I did quite well because I was up and going and offering unique things and services, which I still do.
Yeah. And I want to really hammer that home, unique things. Because the next question is, let me read it and then just kind of tie the two together. Question is, tell us what you're doing to compete for those patients with the hospital. And the magic word there is compete. When you're competing and a patient's got choices, you got to be different and valuable in some kind of way. And the word unique is the lead in. So give us a couple of examples.
Well, we're doing a lot of the guest posts now. We've been featured in Living Well, Microsoft. We're adding expert professional advice and tips, and I have a lot of this on my website. So we're trying to educate the public, and through formats like this as well. My patients are educating other patients because they love this minimally invasive procedure that I'm doing. I have many patients where I've done open procedures on one foot and I've done minimally invasive on the other. At this point, 100% of the patients prefer the minimally invasive because there's less downtime, quicker healing, no sutures, no swelling, everything like that. They get back to work quicker. And they don't have to go through the whole hoopla of all the history and physical. So they're telling people about it and they're leaving good reviews with that. So they're educating as well. I think what's interesting, though, is I can perform procedures on people or patients that typically they might not be the best surgical candidates. Maybe they're a poor healer, diabetic, venous insufficiency, on an anticoagulant. Yet they have a bunion that rubs on their shoe and causes a pre-ulcer and their quality of life is affected. Well, I can do that minimally invasive in the office through needle portals, basically, and get them healed quickly. So I'm offering a service to patients that might not be a typical good candidate for that procedure if we put them under sedation. And that's the difference. What I do in the office, I can do it under a local block.
And can the hospital do the same thing? Could they do the same procedure in the same way?
The thing is, they're not trained to do that, and they do not have the proper instrumentation. It took me years to get to this level of this advanced skill in workshops. I attended many cadaveric workshops. It's kind of a blind procedure under fluoroscopy where I'm using portals 1 to 3 millimeters. I'm resecting bone. I'm cutting bone. I'm releasing tendons. But I mean, it's a great thing for me to do in the office. I was covering for one of my colleagues in the hospital, and she just did I saw her patient yesterday. Excellent outcome. She did a tenotomy on a big toe, chronic ulcer at tip of the toe, had to release the tendon, did it in the hospital, incision well healed, objective met. Great. But what's interesting is I could do that same thing in my office for 5 minutes, in 5 minutes, that same procedure without any of the hoopla. Think of the travel time. Think of practice management. When I do cases in a surgery center outpatient, I've got travel time, I've got history and physical, I've got all these things I have to do. When I do it in my office, these minimally invasive procedures are quick, 20 to 25 minutes typically. And I don't need all of that. And I get paid more for doing it in the office. Blue Cross even pays you 20% more than they would otherwise.
Really?
And imagine if I had easy access to a surgery center. We talked about hospitals, but not as much surgery centers. Remember that 28299 bunion code I talked about earlier, the double osteotomy. Now, if I did that in my office, the reimbursement is much higher than the hospital, $984 compared to $599. But if I did that in a surgery center, the reimbursement is $3,920. Now, if I choose to do it under a local block where I don't need a nurse anesthetist, I don't need all this extraneous stuff like physical therapy, or I can pull up the history and physical from 6 months ago if it's cleared. That means that the administration of the surgery center, we don't have to share those fees, or it's just the surgery center itself. We don't have to allocate that accordingly. So with easy access to there, a lot of these minimally invasive procedures can be performed even in the setting of a surgery center. Probably not so appropriate for a hospital because of the instrumentation. And it's so easy to do in the office, because you look at the time when it's so quick for me to do these in the office. It's not worth the drive going back and forth and all the hoopla on some of these, especially if they don't have instrumentation. And by the way, that figures into it. Hospitals have to look at the cost now of everything, instrumentation. I do Lapiplasty. You probably heard about it. Great bunion procedure. I love that procedure. Very expensive. The fixation can be $4,000 for that. And that's taken off the cost of the case. So all of a sudden, hospitals are re-examining the fixation and any new fixation coming on, because that goes into the bundling as well.
Interesting.
A lot of pressure on facilities. So when you perform minimally invasive like I do without fixation, I'm letting minimal dissection, I'm letting the natural anatomy help the body heal in the right position. I'm letting them walk right away. Great outcomes. I can bypass all that, the fixation costs, the fixation complications, all those things, and have a very happy patient.
Yeah, let's talk a bit about that. So we made it clear on what's better for you, but why would a patient choose to come to your office versus go anywhere else for a same procedure?
Well,
because this gets at like the advantage. This is how you compete, So
yeah, we're talking exactly. And it's finding anything in the market, niche that you can do well, that you're trained in well, and maybe other doctors are not doing. It's swimming with the current of the river and not against it. A lot of things I do is not what I necessarily intended to do, but I'm doing it because that's where the river lets me sail to, durable medical equipment at all. But with respect to this minimally invasive type surgery that I'm discussing, the advantage of that, as I mentioned earlier, I do this through small portals, no incisions, 1 to 3 millimeters, minimally traumatic, so there's less pain. There's no sutures, and usually that portal heals in 4 days, whereas if I use sutures, I'm taking them out at 3 weeks, my patient can get their foot wet in 4 days. There's no scarring. It's more aesthetically pleasing, quicker recovery with immediate walking. I don't use fixation, so I use my external bandaging to fixate it and set the position there. Lower complication rate. And again, I can perform these procedures on other people who might not be the ideal candidates. Minimally invasive surgery has become the standard of care for diabetic forefoot ulcer, where I do an elevated floating osteotomy, basically. Through a needle portal on the forefoot, I free up the tissue and I make a bone cut in the head of the metatarsal so it floats up. It alleviates the pressure. I can even do that if the HbA1c is elevated, because I'm concerned about healing a needle poke, not an open wound where I because I'm creating another wound in that sense. So Minimally invasive has been a great feature for many patients. Chronic swelling is another issue. Blood thinners. As long as they have enough flow to toe, and that becomes important. And there's sometimes I do need to assess that. They do need flow to toe. Arterial study is very important on there. But if they have flow to toe, it's a heck of a lot easier and quicker to heal a needle portal or 1 to 3 millimeter portal as opposed to a 4 centimeter incision.
Yeah.
And they can walk right away, and I'm finding they get back to work. And that's a big thing in this day and age too. Now, how much time am I going to need off? I love the Lapiplasty. I do that procedure, great results. But that patient is pretty much, it's a 4 months procedure before they're back to normal. You know, in 6 weeks, they're not really doing much on that. In this day and age, we'll have to work, you know, so they need something that gets them back quicker. Yeah.
So there's a lot to kind of sort of summarize here, because there's a lot of good stuff in here. So we had a different episode with another guest, and the theme of that was, it was on marketing, but it was, you know, do the marketing that the big guys cannot do. There's things that there's services, there's things that the big guys just can't do. They're too big, they're too lumbering, they're too constrained by their own procedures, by their own requirements. And so one of the messages here is, if you're a private practice and you're worried about them, worry a little less. Just because they're bigger doesn't mean they're better. And so find what they're not doing.
And it's something that ties to that. I actually get referrals from these hospitals.
And then make them aware of it. Yes.
I get referrals for this minimally invasive procedure because I do them. So I actually get referrals from the podiatrists there and from the doctors for some of these niche things that they don't do, because they know that I do them. And the patients tell them and show them the results, and they're happy with them.
Yeah. And don't fear. Like the reason I asked the question, why couldn't they just go to why couldn't the hospital do it? And your answer was, well, I suppose they could, but structurally a lot would have to change, and they're not very good at that. Well,
they could, but they don't have the training, the skill set in this. Nobody does this minimally invasive, but me in my region locally. There's some others in the state, but it's an advanced training. So it's looking in your medical field and finding some of the unique things that can be very beneficial. And this isn't new, by the way. General surgeons, orthopedic surgeons do many forms of minimally invasive procedures. You know, they use robotics and all that, but they're doing larger cases in the hospital typically. In my profession of forefoot, it's very easy to numb it up and do procedures in your office and bypass a lot of that. And we're exempt from a lot of those rules because we're not using conscious sedation, so we can actually perform these procedures in the office.
There it is. And so you're finding something different, something that they don't do, and you're doing it better. You've got an advantage. You're keeping your advantage. What are you doing to kind of make people aware that you do these things that the hospital doesn't do?
Well,
because that's the other part of it. If you're better at something, but nobody knows about it, then you don't really have much.
So this is where, you know, we talked about we've had guest posts on Living Well, Microsoft. We've developed a lot of tips on my website, which we feature a lot. I've talked to a lot of physicians, but my patients have been a great proponent of this as well, talking to their doctors as well. And we're really developing this campaign and things like this as well to get awareness out. We're seeing a big enthusiasm with minimally invasive procedures for many of the reasons I mentioned earlier, getting back to work quicker. A lot of patients don't want a surgery. They fear a surgery, but when I explain it to them, I mean, to me, it's not that much different than performing like an ingrown toenail removal.
I was literally just thinking the same thing. Literally, yeah. It's like,
because if you compare, minimally invasive.
Yeah.
Granted, I'm inside of, I'm going through a portal. I'm inside the bone. I'm doing minimal dissection is being performed often with needles or very small instrumentation and burrs that the hospital doesn't have that I use. But this takes advanced training. That's why not a lot of people can do it, because if people start doing this without the advanced training, there's going to be a lot of problems.
Yeah.
Kind of Stevie Wonder blind surgery, so to speak. I'm using a fluoroscopy. I'm developing a lot of my other senses, the feel, the sound, and all that. And I've had years of experience with that. And there's a tremendous learning curve. So it's not something that you're going to do right away. You attend workshops and gradually pick more and more. But as I mentioned earlier, this was perfect for me during the pandemic when everybody was down. Guess who was the only one up?
I'm open. That's right. Come over here. It's so true. And develop the advantage, and then you got to keep it, but you'd have to keep your, continuing ed up anyway. So absolutely. And every field's got some corner of it or some piece of it that few of your colleagues, whoever you are out there listening, aren't paying attention to. And you can, as long as you think it's not this super rare thing, you can too. And that's a totally legit way to compete when others seem bigger and, gnarlier. And how would I fight them? You don't fight them on the same battlefield. You go to a
Correct.
different battlefield where they aren't, and you let them have what they have, and you go take the rest. Love it. Love it, love it, love it. So what's next for you? Like, is it, are there more, you don't have to disclose anything, but are more procedures coming, more education? Like what's,
Yeah, that's exactly what we're doing. It's kind of fun because it's such an exciting field that I'm in with the minimally invasive, promoting that, knowing that I also do open procedures. So I basically have a lot of tools in my tool shed that I can do. And the other thing is it all revolves around the patient. It's not me or ego or anything like that. I can do what the hospitals do in a sense. It's all about the patient, what is best for the patient. And I like the patient to be educated. I encourage them to go to my site and read about the different options so they can be educated because it's what's best for the patient. I've got to consider their comorbidities, their work schedule, things like that. Is this a good procedure? Because I've had patients where I don't said, this might not be the best procedure for you as well, but I can focus my attention on the patient as well with that. So I like to continue to educate people about the advantages of minimally invasive procedures and continue to build that part of the practice up because I think it's the wave of the future, especially with everything going on in hospitals right now. Like I said, with the caveat, I think we're seeing things change now. I think things are going to get a lot more difficult and challenging as they integrate this for all sorts of things, the bundling that CS is requiring on them, where I have the independence on the outside world being a solo practitioner. So I don't have to worry about all of that or the politics or all that bundling.
I know. It just, who knows if or when it's going to happen, but there's just more strain every year on trying to squeeze more output out of a shrinking, reimbursement. Like eventually it's gotta start bursting. It just does.
Well, another interesting thing is I can offer these self-pay and people come from different states. When you're offering a unique service, you can actually do self-pay in cash. Many of my colleagues who are advanced in this do that as well.
Yeah, see, and we didn't even get into that one. So for another time, but man, it's such interesting information. It's really, it's like just a classic sort of, strategy of how do you win when you've got competitors who on the surface just seem like unbeatable, but they are. A couple of wrap-up questions. The first is, we covered a lot. Is there anything you think I should have asked you in the context of what we talked about that listeners need to hear about, but I just didn't ask you?
I think we're pretty thorough. I've reiterated that on this kind of niche thing that I'm doing, because not everybody should just start doing this. It's a skill set, but I think it's the same, like you mentioned before, in any vocation, it's finding, where is a need and developing that skill set. You can stand out as well and seeing what other people aren't doing and what is the need based on the population there. I have a lot of diabetics here in Louisiana, so my minimally invasive procedures work great on them. Sometimes I'm addressing an ulcer at the tip of the toe and I need to make a small cut in the bone to make that toe straight or release a tendon. So I have a huge population base out here of higher risk patients that I can help heal. And I look at these as limb salvage cases. If I don't do this, this patient can likely lose his toe and lose his foot. So finding your, in your community, what is needed, your population as well, and finding the niche, for that.
Yeah. And so what a lead into the other one, which is, all right, we've caught somebody's attention. They're facing this, or they're wondering about it for themselves. The question is, what are one or two tangible steps you would advise they take, as soon as they're done listening? And I think one of them is, what's a niche patient population in your area, that you look at and go, I wonder how well they're being served. And then another one, we can have more than two. Another one, just basing off of what you said, I would say is, take a look at what your competitors are able to do and look for gaps. You may not be able to solve it today, but if there's just a sizable enough patient population that's being ignored, they don't have to be ignored forever. You can step in.
Exactly.
And anything else I kind of asked the question and answer it myself. Are there any other, steps you'd say you've been down this, because you've been down this path, looking back?
And I had the advantage of, I anticipated, I keep up with a lot of things. So I saw this coming down. I was able to prepare myself. So I didn't really see the downslide that a lot of people did. I had plenty of time to prepare myself and like I said, the time of the pandemic and
Yeah.
all. So a lot of that in medicine, like you said, is very dynamic and changing. You really have to be on the cusp of things. You need
Mhm.
knowledge you can find at conferences and whatnot, to kind of know the trajectory of where things are headed and anticipate. A lot of people work in the big systems. They don't know what's going on. They're not into
No.
the politics. I talk to them about it. They're clueless. I know people, and it's
Because they're
interesting. In
employees, and
private
it's like an employee mindset, right? Which is different than an owner mindset.
they're employed exactly, but when you put up the numbers, like me, I can perform the same procedure in my office, same coding, be reimbursed at a higher rate. In my case, takes 20 to 25 minutes, and they have all the hoopla of doing all that unnecessary things that I think, do you
Yeah.
really need to sedate the patient for that to not all these different things, that quick procedure that I can do in 5 minutes? Again, practice management. I can see many more patients, do many more
Mhm.
procedures in that time window than what it takes there when you think of all the delays in that. So practice time management, this comes into play as
Other
well with
benefits.
travel
Yeah.
time
It
back and
ripples. It ripples,
does that,
doesn't it? Yeah.
uh, very important.
Yeah, absolutely. Well, Dr. Formanek, thank you. Thank you so much for sharing this story. It's super interesting on a ton of levels. I really appreciate you taking the time and coming on.
Thank you.
Yeah, so we're going to put the contact information that you gave me into the show notes for your episode so that anybody who's curious, they can check out your website, start to see what you're doing and how you do it, and just learn from that. That will make sure that that becomes available. A couple of other points
Right.
before I wrap up. First, if you're like Dr. Formanek and you've got an experience with the business side of your practice that you think others would benefit from, or if you're someone like me who seeks to serve private practices, same thing, you've got some expertise you want to share, we really want you to come on PracticeCare and tell the world about it. In the show notes for Dr. Formanek's episode and every episode, there's a link, couple of questions. Tell us what's on your mind so we can get you scheduled as soon as possible. And finally, if you haven't done so already, please subscribe to PracticeCare on Apple Podcasts, all the other platforms we are on. Just search for PracticeCare and you'll find us so that you can stay up to date with episodes. Thanks very much. And until next time.